in the cloud. All right, cool, we're recording. So good morning, everyone, and thanks for joining us. I'm Kraut, I'm the program director at the University of Wisconsin, and I'm joined this morning by members of both the Department of Emergency Medicine at the University of Wisconsin and at Medical College of Wisconsin. We had planned, of course, to conduct our panel discussion in real life at the SAEM Academic Assembly, and we hope to share with you this morning our blueprint for developing a peer support network at your institution. So unfortunately, we're gonna have to do it virtually. While our respective peer support groups were both developed well in advance of the emergence of COVID, I know the pandemic has certainly highlighted the prominent role that these types of networks can play, whether in times of crisis or just in the day-to-day challenges of life in the medical profession. So our primary goal today, as I mentioned, is to provide you with some insight in how to approach the challenge of establishing a peer support network at your home institution. So today we'll present our experiences with this process and hopefully provide some examples from two programs that are currently at various stages of implementation. So without further ado, let's meet our panelists and kick this thing off. So Brian, can you tell everybody who you are and kind of what your role is?
Yeah, hey everybody, I'm Brian Sharp. I am an associate professor in the Department of Emergency Medicine at University of Wisconsin, where I also serve as the patient safety officer for UW Health. And partnered with Chris and others to start our departmental peer support program, and more recently our system peer support program.
Awesome. Well, welcome, Brian. How about you, Alicia?
Hi, so I'm Alicia Pilarski. I'm an associate professor in the Department of Emergency Medicine at the Medical College of Wisconsin. I currently co-lead and was one of the founders of the Freighter and Medical College of Wisconsin, supporting our staff peer support program.
Awesome. Well, welcome. And how about you, Chris?
Hey, I'm Chris Vandivort. I'm one of the clinical instructors in the Madison UW Emergency Department. And I just finished my wellness fellowship in June, and second victim syndrome type of work was a really, really big part of what I had the opportunity to do in our department.
Well, such a pleasure to have all three of you join us. So I wonder if we could just start out by talking a little bit about what do these programs actually look like at both of your institutions? So maybe, Alicia, you've got kind of the more mature program timeline-wise. You can tell us a little bit about yours first, and then I'd like to hear the contrast from Brian.
Great, thanks, Aaron. So yeah, our program has been in establishment for as an institutional program since January of 2019. We're based off of a three-tiered model, which is familiar in other institutions as well. Primarily, we looked at the University of Missouri's 4U team as kind of our model for development of the program. There are three different tiers. The first tier is basically the entire clinical care team and any other additional administrative support staff and so on. And this tier is a group of people that we are just trying to bring awareness and education to kind of help identify second victims or situations that may cause distress amongst the healthcare team, in the clinical environment. The tier 2 is actually kind of the crux of the program, where it's a trained peer supporters made up of individuals such as nurses, physicians, residents, other techs and staff, and so on. They receive an additional amount of training to recognizing situations that could cause distress in their colleagues, as well as how to provide peer-to-peer support, either one-on-one or within group debriefings as needed to. And then our tier 3 group is a group of more advanced peer supporters, so those with backgrounds in psychology, psychiatry, social work, EAP, spiritual services, and so on. And this is a group that also provides some immediate peer support to a colleague who may need some advanced support if they're suffering, and they help align our colleagues with any other additional counseling or therapy as needed. And as a group, we meet quarterly, and we kind of work together going through peer support encounters, as well as continuing to develop the program.
Awesome. So really an established infrastructure. Brian, how does that compare with what we have at UW?
Yeah, I think it compares really similarly, although our program is much newer, as you mentioned, Aaron. We've had a program in place locally in the emergency department for approximately a year at this point. More recently, in light of COVID, the anticipated needs to support staff, we have rolled out a hospital-wide program, but I'm really going to focus largely on our work in the ED, given that has been ongoing for a longer period of time. So our program in the emergency department is also based on a kind of the same three-tier program concept that's pretty pretty common throughout peer support programs nationally, and was influenced largely by some of the systems in place at University of Missouri, but also at LA County and New York Health and Hospitals. We also focus largely on that tier 2 one-to-one peer support, and then we have group support as needed, but that comes in our case largely from tier 3 resources. So we have a roster of approximately 20 peer supporters from different care roles throughout our emergency department, and that spans across our 2 different emergency department sites that we work at clinically. So we similarly have a steering group that meets monthly, and that was a group that was meeting for a number of months in advance of the launch of our program, and continues to meet monthly to talk about potential changes or modifications or ways we can improve our program. And then we have our entire group of peer supporters that meets quarterly for similar kind of programmatic updates, but also an opportunity to debrief and to support each other, which is a really important element to this work.
Gotcha. So commonality is certainly a tiered structure, and then some kind of recurring meeting for updates. And we'll talk about how to maintain some momentum later. So that's great. We learned about the infrastructure, but I want to backtrack a little bit. And Chris, I'm curious from your perspective as a recent wellness fellow, what's the big deal with peer support? Like, why set up one of these programs in the first place? What's the impetus for doing this?
So, in talking to people involved in peer support at other institutions, it seems like a really big commonality is that these programs are often based around someone who actually suffered from second victim syndrome, whether that's one of the program leaders or someone nearby. And I think our program really has a similar origin story, which is that one of my co-residents had just terrible, terrible second victim syndrome symptoms after the passing of some pediatric patients involved in a horrible car accident through no fault of his own at all. And then kind of to even just speak more broadly, I think there's just this need out there, and especially in the emergency department, because we really see any patient with any problem, which, at its worst moments leads us to, deliver devastating diagnoses or to watch young people die. And I think that you can see that people are suffering from this, and that sometimes that's underappreciated in sort of the macho culture of medicine, where we're all expected to just, swallow our suffering and ignore it. And so part of what we actually did to sort of assess this needs out there is we did a needs assessment survey, and we actually found that in our department, a lot of people are having these experiences, but nobody's really seeking counseling. And the research is pretty compelling about the role of peer support in helping to rehabilitate second victims and get them back into their prior level of emotional functioning and their functioning at work. And so that was really the impetus for us. And I think that's really a common experience you hear about in a lot of other programs.
And Chris, I would just add one thing. I think you mentioned counseling. I think that's a critical piece here, is that really one of the places that I think peer support adds a ton of value is that it's often a lot easier, and that barrier, that threshold to obtaining support is a lot lower if it's your colleague, if it's your peer, than reaching out to some of those tier 3 resources. And we even see in this work the number of cases that require or end up leading to referral to a tier 3 resource is so low. But just because they don't need formal counseling, really doesn't mean that they don't need support. And that's where I think really peer support fills that void. So I think you kind of highlighted that really nicely.
I totally agree,
Yeah,
Brian.
it's so true, right? Like, I'm much less wary about talking to my friend or colleague about a difficult case than I would be about signing up to counseling about it. So, all right, you've convinced me. This is really a worthwhile effort to undertake. So let's say I'm at a program, I don't have a peer support network in place. How do I decide that our program is ready to set one of these things up? And when I'm assessing the readiness, what barriers can I anticipate running into, and how do I navigate those?
Yeah, that's a great question, Aaron, and definitely something that even if you recognize the need personally, I think it's critical to undergo that needs assessment, or that kind of readiness assessment, to see kind of what difficulty you're going to encounter or run into as you work on launching a program. So when we launched our program locally, we had initial conversations with departmental leadership, and then also leadership throughout the institution, and that included talking to stakeholders in risk, legal, employee health, hospital leadership, including CMO, CNO. And we did also go to our provider well-being committee, given their kind of engagement in work like this. And there was definitely general support across all of these groups. I think everybody recognizes that this is a worthwhile idea. But definitely were a lot of questions about primarily logistics over things like where this would live, who would lead this work, how it would get funded, what the structure would look like, and just different opinions on all of those things. And so there was agreement to start a needs assessment to help answer these questions and to work through that. But we knew that that was going to take some time, probably a year, if not longer. And what we thought was, we had this opportunity and this really glaring need locally to start something in the emergency department on a more immediate basis. And so while we were working on the system-wide work and looking at a system-wide program, we actually simultaneously started working on launching an ED-specific program that, part of the benefit of that was also could be used as a proof of concept of peer support, and this proved to be the case.
Awesome. Alicia, does that kind of mirror some of the stuff that you ran into when you were starting up your program?
Yeah, absolutely. So we actually, our efforts in the emergency department is where this all started as well, but much more grassroots effort years ago when this became a need. And going back to Chris's conversation about, being in the emergency department and being exposed to so many of the tragic cases and difficult cases that we see day to day, there was just such a need locally. And so we basically created a small committee of nurses, a physician assistant, myself, and a resident to kind of start our small peer support program within the emergency department. Interestingly enough, though, it had gained such success and awareness that it showed up on the patient safety strategic plan for the academic year. And this happened about a year and a half ago. And so we then I was asked to kind of co-lead this with the director of patient safety at our hospital to make this more of an institutional program. So, and again, could not agree more, getting the stakeholders of risk management, patient safety specialists, CMO, CNO, nursing managers, and leadership was critical to get them involved. And really just, I think the other part too is like finding those really passionate and people who are on the front lines who recognize this and have experienced it themselves, to get them involved early on too, to be a part of the development of this. That really helped as far as like making the program stick early on.
Yeah, so true, right? To get those champions that are really invested on board early. And as I mentioned to you guys earlier, it's so cool, number one, that these programs were spearheaded by people in the emergency department. This is just yet another reason why our specialty is awesome. But I think furthermore, right, Chris was a fellow when he did this. You mentioned that there was a resident who was helping you to lead your charge. As a program director, it really warms my heart to see that there are learners that are kind of leading the charge here. So let's talk a little bit about logistics. So you decide you want to set this type of program up. We think about what type of stakeholders we need to involve and what barriers there might be. So what do you do next? Like, how do you set up and train the support team? And who did you train, and how did you decide who to train?
So one of the things that we first did was we looked to the experts, right? We tried to find who out there has done this program successfully. And so we actually reached out to Susan Scott from the University of Missouri's Developed For You team and talked with her and what their team had done, kind of getting a little bit more information about the logistics of their program, and then had actually invited her to come do our initial training session. And that was back in January of 2019. So one of the things too to kind of think about is that initial training session, we were really careful in selecting people that we knew would be really critical in helping develop and get this program kickstarted, and to be someone that would be, bringing it back to their departments and their units and really kind of being a champion for our program. So the initial invite went out to all the chairs of the departments and asked for colleagues that were trusted and approachable, and they would be nominated by their chair as someone who would be a good peer supporter for their department. And then those individuals were asked to select a partner from nursing or staff. We've also had patient safety specialists, and like I mentioned, some of our residents and stuff as well. And so that was the initial first training session that happened. Since that time, and again, it was like a really important group, and we met monthly right after that initial training session to kind of continue developing the program. And then since that time, though, we've really expanded the training, and we do since the train the trainer model. So we took all the information that Susan Scott gave to us, and were able to adapt a training program that was specific to our institutional program. And then since that time have trained really anyone who's interested at this point to kind of help spread the word and get more peer supporters out there. And at this point, we're at about 150 trained peer supporters throughout our institution, and more on the list to be trained as in the next couple months here as well. So that's kind of where we're at and how we kind of started our training sessions.
Super impressive in just a short amount of time. So Brian, as a relatively younger program, how does that compare with how you set things up?
Yeah, I think similarly. In our case, actually, our content expert was Alicia. She's right about an hour and a half away. So she was kind enough to come up and do our initial training for our emergency department program peer supporters. And, you know, similarly to Alicia, I think we were really thoughtful in who those initial peer supporters were, just so critical that we had engaged people who are also going to be successful and able to successfully provide peer support to help those that needed it. And so a lot of our kind of selection early on was just through knowing those people really well, either knowing that they were already interested and engaged in this work. There were some people who had some background, or just knowing, you know, their personalities and knowing that they're, you know, trustworthy people who are really kind of those natural supporters that just, you know, really need to be kind of plugged into a framework, if anything, and given maybe some additional skills. So for ours, as I mentioned, Alicia came up. I was also able to attend a training at New York Health and Hospitals led by Dr. Eric Way, who implemented a program there and at LA County. And then I was able to take a lot of that information back, kind of similar to Alicia for the 4-year program. I was able to take some information from the Helping Healers Heal program and share those training materials with our group. And also kind of just take some of the infrastructure, elements that I learned there. For our system-wide program, it's been interesting because, as I mentioned, we launched this after COVID, or really in response to COVID, and pulled it together on a extremely tight timeline. We from decision to implement to launch, I think we did it in about a week and a half. Which was crazy, but that was right in the midst of all of this emerging. And for that, we had to do virtual training sessions. There was no way we could pull together large groups of people and do some of the things that do add a lot of value, like role play. But these ended up being really successful. We actually did 3 virtual training sessions over a 2-day span, trained like 75 peer supporters between myself, Chris, and another project lead. And then we actually did record the last of these sessions and have continued to add peer supporters by having them watch those and then complete some independent learning. So we've done it a couple different ways.
Awesome. Well, I, for one, am really encouraged by the fact that virtual training has gone so well for you, because here we are in a virtual setting. So hopefully people are going to find real value in this. Chris, I want to ask you, because I know you've been involved a lot with kind of data collection and tracking. I imagine for a number of reasons, it's important to gather some data about these programs, both to demonstrate efficacy to stakeholders, but also to help with kind of improvement processes internal to the program. So can you talk a little bit about that? Like, how did you decide how to collect data? What do you collect? What's important, and what did you find is kind of worthless and we don't collect anymore?
Aaron, I think you're totally spot on in that data collection really is pretty important and definitely something to think about a little bit ahead of time. And I can tell you the solution that we use. Just a couple things to consider is you're totally right. It's really important to have good data so you can demonstrate to the institution to get that the programs are working, and they love to see data. And also it's really important because then we can sort of track where things are in the department, where there's more need, and how we can best refine our second victim support syndrome support system to best meet people's needs. So we use, after a lot of discussion with our risk management team, we use an anonymized Qualtrics survey. And I think this also captures another thing really well, which is that it's very easy to use. It's just a page and a half on Qualtrics. You can do it on your phone. It takes about 1 minute. Because I think what you find is our peer supporters love supporting their peers, but much like ER providers, they're not too big on the documentation aspect. So I think ease of use is a really good way to reduce friction. We have it anonymized with regards to the patient and the peer who's receiving support. So we have our peer supporters enter their name, but they don't provide the name of the person who's receiving the support. And similarly, we don't capture the date or the specifics of the patient event. It's very general. It's, pediatric death or failure to stop progression of disease, some category we can lump it into. and then the month and year that it occurred, so that we can sort of track the trends in the utilization of the program over time. And then the last thing is that we've really kept it to be a living document, which is that, as we've discussed, we meet with the full team quarterly, and we get a lot of input from our teammates about, what's working, what's not working, where there is more need, and what sort of data we do want to keep capturing. And I know Alicia has discussed, and maybe I'll just toss this over to Alicia, because she's sort of discussed how theirs is a living document too, and how it's changed with regards to violence versus staff.
Yeah, so we did a very similar model as well, having the call checks. I think it's a great way to, it's so easy to use. We actually also send it out every Monday as a reminder, just kind of, again, like, sometimes you're on the weekend and you support someone, you don't think about documenting. So every Monday this comes out to all of our peer support team. And yeah, again, I think it's really critical, like recognizing that it is a living document, then adding categories as needed. Like when we would be meeting with our peer supporters, we had noticed people putting in the other box for reasons of providing support was because of violence against healthcare workers. And so tracking, being able to like recognize that there was an uptick in that, and how to provide more resources to the team members of how to deal with this. Is there an issue with violence in our clinical environment, and actually bringing that information back to the hospital as well. And then actually, even with this COVID time, we were able to add to our Qualtrics survey is, was this support related to COVID? So I think just having that flexibility, but using this documentation is a good way to kind of help guide additional resources, as well as kind of seeing where the resources are being utilized and how they're being utilized is really important.
Yeah, so true to have that objective data to go back to leadership and say, look, we need resources here, or we need to do something on the front end to address this problem rather than just reacting to it. All right, so you guys have totally sold me. Like, I'm on board. I want to set one of these things up. I know all the kind of barriers to look out for, the right stakeholders to engage. So I get it up and running. Everybody's rah-rah about it. How am I going to be ensured that a few months from now, it's not just going to totally deflate and we're going to lose momentum? Like, what kind of things have you guys done to make sure that this stays running strong and people remain engaged and invested?
Yeah, I think, oh, go ahead, Alicia.
Oh, I was just gonna say, one of the things is really, I guess those quarterly meetings are really important to have. I think that's like one of the things to keep things going. We do also send out some like monthly emails and updates and things like that to the team, but really making a program out of it. So, and I'll let Brian kind of talk a little bit about this too, but really kind of creating a name and a brand, if you will, creating brochures and flyers, web pages, and then really going, I think for myself, I went on like a dog and pony show throughout the entire institution, just kind of talking about the program and the development of the program to all sorts of, residents, students, nursing management, nurse leaders, physicians, and then just providing a lot more educational material to our actual peer supporters to take that back to their own departments and units was really beneficial too, because again, me coming to their department is great, but their own colleague coming to talk about the program from their point of view and why it would be important to them, I think was also really critical.
Awesome.
Yeah, I was going to say the same thing. I mean, I think that's pretty, that playbook is pretty kind of standard as far as like the best way probably to go about it, which is, create a clever name. And I think, Alicia, I like your guys' name a lot. Ours was kind of thrown together at the departmental level, but we'll need to vet a name for our system one, because I like yours a lot. But yeah, I mean, it's just, finding the right people that are going to be engaged with this work, finding the right people who are going to refer cases, right? So like for the ED, it's, thinking about groups like social work. I mean, they're going to be involved in all these difficult, sticky, kind of awful cases. Charge nurses have their finger on the pulse of the department better than anyone else. So, trying to really work with them to make sure that they're familiar with the resources, that they're comfortable as a tier 1 resource, but also that they're going to refer cases. And then I think, just looking for other places to integrate this work in. And I know, Alicia, you guys are further along with your program, but, looking at some of the avenues where this can be needed, whether it's through, the RCA process or peer review process, where are those cases going to come up, or where are people going to feel those emotional impact, or that emotional impact where peer support can really be helpful. So I think it just continues to kind of grow and spread, and just constantly looking for other places where it can be either utilized or different ways it can be utilized.
Cool. Plus, I'll add to that list, you got to have a really cool logo, right? I see some cool logos behind us. All right, so you guys mentioned COVID quite a bit, and like it or not, we're still dealing with this. So what kind of changes have you made to your respective peer support networks in light of COVID? How have you had to adapt and kind of be flexible?
Yeah, I mean, I think ours obviously had a huge change, which was we didn't have a system-wide program prior to COVID, and there's been a lot of negatives that have come out of COVID. But I think this was one of the positives was we were afforded this kind of opportunity to launch something that was already in the works, and I think it helped immensely that we had the ED program already in place. We had people aware of it. They were already excited about expanding it system-wide. Almost all the stakeholders we needed were already on board in at least looking at this. And then we'd already started, with some infrastructure in place as well, whether that was the training materials that were already roughly built or that we'd used for the ED training that we could just modify, or even things like the survey. It just helped expedite that along, where we were able to get it launched in about a week and a half or 2 weeks from approval or green light. So I think despite that, we've definitely seen a very different manifestation of some of the second victim syndrome, or even just the stressors of work. I think traditionally second victim syndrome, as Chris was talking about a little bit, is related to those really difficult cases, or sometimes it's various things, but that's often historically what's talked about, and it can just be a combination of those. But I think what we're seeing is just a different kind of this basal rate of stress from things like exposure risk, financial strain, changes in the way that we're all working, different tasks. And I think we're really seeing that from our staff, and they're really utilizing the program in light of that, or in response to that. Additionally, we have started doing some things like we're doing regular peer support rounds on some of the largely COVID or more primarily COVID affected units, really with a couple of different aims. One's to provide support to the staff, as well as just express gratitude and appreciation for the work being done. And then also just to create awareness, given that our system-wide program is brand new.
Gotcha. Yeah, that definitely makes sense. Alicia?
Yeah, we've had to do some adapting as well, but it's also been, again, kind of accelerated the growth of the program in a lot of different ways. So one, we were planning on doing an online kind of learning center module for our training, just because we were going to expand through our enterprise in the next few months. So the COVID pandemic definitely accelerated that. So creating an online module and having smaller in-person sessions for kind of discussion about cases and so on. So we're in the process of finalizing that right now. The other thing that we did, very similar to you guys, was the proactive rounding on the COVID units. And so we had a self-selected group of volunteers who, both from our tier 2 and our tier 3 group, who actually went to the COVID units and checked in with staff and providers who were really feeling the high stresses of caring for of the sickest patients in our hospital. And again, just the unknown of what was going on with the disease process and everything else. So that actually it was so successful and so valued by those units that it was escalated up to the hospital level, saying, we need to do more of this. And as of this week, we're actually expanding that program and actually going to all units in the hospital, just because we recognize that there was so much great feedback even coming back, again, with resources related to just day-to-day operations within these units as well, but allowing an ability to provide real-time resources and support for all of our colleagues on those units.
That's awesome. That's so cool to hear about just the proliferation and the rapid success of these programs. So just in wrapping up, I want to ask each of you guys, and maybe we'll start with Chris, what are the biggest kind of take-home points or lessons you've learned from all this? If you're talking to me or someone out there that wants to set up one of these programs, what one or two pieces of advice would you give them?
I think one of the things that's been most amazing to me is that if you get the right people on the bus, to go back to good to great, it's really amazing how the program just kind of takes on a life. I remember one of the quarterly meetings, I asked one of our peer supporters if they were getting burnt out, and they were like, no, this is work that keeps me from burning out on my normal job. And they're just so passionate about it. And I think if you find those people, it's just amazing what they'll do with this sort of program.
Awesome. Alicia?
Yeah, I think I echo that 100%, Chris. I think that's really important. The other thing is, don't reinvent the wheel. Collaborate, reach out to others who have done this. I think the partnership between Freighter, MCW, and UW Health, as well as just again, Missouri and all the other institutions that have these programs, they have people who, again, are also equally as passionate and willing to share and help you along that way. So don't be afraid to reach out. And I think that actually helps kind of create a better, more robust system early up front, instead of kind of trying to figure it out on your own.
Wonderful. What about you, Brian?
Yeah, and I know, I just to add to that, Alicia, I think I know hopefully it's okay speaking for you, but I'm sure it is, that any of us would be happy to be contacted if you guys have questions or if we can help in any way. So I would second that. I think for me, the biggest takeaway is just not to overthink things. And that kind of goes along with or piggybacks on Alicia's comment. But, I think this can be a little bit overwhelming, just to think about, oh my gosh, I'm going to, start this new program. But I really think it is something that once it gets going is actually requires very minimal resources. It just, it requires someone who's passionate about this. And I think it is something that is almost universally well accepted and welcomed. And people, there's just such a need for it. So I think just not overthinking things. It doesn't have to be perfect. I think just getting something launched that checks the right boxes and gets the right people signed off, can eventually grow into a really successful program.
So true. Well, thank you guys all again for joining this panel discussion. Obviously, you all have much to be proud of in terms of the great work you've already done in setting up these programs. And as Brian said, I'm sure that any one of us would be willing to chat more with folks out there who are staring this down and saying, I'm going to set up one of these programs and how can we help? So thanks again, guys. And I hope you enjoy the rest of your days.
Thank you, Aaron.
Thanks, everyone.
Thank you, guys.